All right, good afternoon, everybody. For those of you who don't know me, I'm Karina Sulaiman, and I work in medicine and nephrology. My topic today is nephrolithiasis, a primer for the internist. We're going to talk a little bit about kidney stones today, and as you will see, this disease entity is becoming an increasingly important issue, both for general internists, nephrologists, and urologists, so I thought it would be a good idea to review it. Don't have any disclosures. All right, so my objectives today will be to review the epidemiology and impact of nephrolithiasis in the population. So we're going to talk about why this is important and why we all need to know a little bit more about it than most of us do. We'll discuss the risk factors for the different renal stones, talk about which of them are modifiable and which of them are not, and then discuss a few treatment and diagnostic therapies that are in use today. Okay, so the prevalence of nephrolithiasis ever since it was discovered, which is back before the Hippocrates Oath, because I'm not sure if all of you know this, but when the oath is taken and we say we're not going to cut for stone, that's the stone that we're talking about. So the prevalence has increased markedly by then, as documented by several large cohorts, the biggest of which is the NHANES data, which they update every couple of years. And the good comparison is that between 1994 and 2012, which is the latest data that we have in terms of big cohorts, it's increased from 1 in 11 to 1 in 20, so that's pretty frequent. Nearly 11% of men and 7% of women report a lifetime stone event, and the populations that are more at risk are men, Caucasians, obese individuals, patients with diabetes, gout, and patients of lower socioeconomic status, which they've defined into different quartiles, and as it grows lower, they're commoner, which might or might not be related to the modifiable risk factors that we will discuss later. Interestingly, even though there is a lower prevalence in women at the moment, the incidence in women is rising faster than it is in men. So the next decade around, when this gets reported, most likely their incidence would probably be equal, but at the moment it is more common in men. It is least common in African Americans, with Hispanics and Asians being somewhere in between. As far as recurrence, about half of your patients are actually going to recur within the first 5 years if we do not treat them or address any modifiable risk factors, and this is why this is important, because as you will see in the next slide, the disease carries significant morbidity as well as significant costs. So if we don't try to prevent at least recurrence once we identify it, we're not doing the medical system or the patient any favors. Okay, so another reason this is important is it's costing us a lot of money. The cost went up again. We have data from 1994 and data in 2000, and it doubled from about $1 to $2 billion. And this is despite that the shift of the increased cost going from the inpatient to the outpatient setting. So as far as inpatient treatment for nephrolithiasis, the costs have actually decreased, as well as the number of admissions, because we're managing it a lot more at the outpatient setting. But because of the frequency of presentation, as well as the cost of the various maneuvers that we are using now to treat nephrolithiasis, we still have an increase despite shifting it from inpatient to outpatient. There's also a significant amount of time lost from work. This is a very painful condition, so patients tend to take off from work when they're recovering from it, and it's about 19 hours a year. And the estimated cost per person per year for those on treatment is about $3,500. So this means this would include those patients who are getting medical and surgical therapies, which is what has driven the number of this dollar amount high. Okay, why else is it important? I mean, this is a disease for urologists and nephrologists, right? The rest of us shouldn't be too concerned about it. Not really. So an increased risk for coronary artery disease has been reported in several studies in the past decade. I just chose to highlight the biggest one of the biggest ones, which was published in JAMA. It was almost 20,000 patients. They followed these patients prospectively, and they showed that the risk was increased in women but not men. There are plenty of small trials that are showing an increased risk in both populations. But as far as being a good trial, this was really one of the best ones. So we think that there is an increased risk for coronary artery disease in these patients. And again, why it might be tied in with the various other risk factors, but as you read these studies, they do say that they do make up for confounding and do multivariate analysis, and evidently the risk is still there. How about end-stage renal disease? So stones are implicated in as the cause of ESRD if there is complete obstruction, and that makes a lot of sense. But in addition, just episodes of nephrolithiasis from which one does recover also increases the risk of chronic kidney disease and end-stage renal disease. And again, one of the largest cohorts was this Alberta Kidney Disease Network, which is actually out of Canada and was published in the BMJ. So a disease that is relatively thought to be benign, possibly implicated in some pretty dangerous systemic diseases. Okay, what else? Obesity and weight gain have also been shown to be independent risk factors in both genders, but nephrolithiasis itself has not been shown to cause obesity. Diabetes, however, a reciprocal relationship has been shown for both. So if you have diabetes, you are at a higher risk of getting nephrolithiasis. If you have nephrolithiasis, you have a higher association with diabetes. Not very robust data out there for this, but it does exist, so I wanted to bring that up. Hypertension also appears to be a risk factor for the development, nephrolithiasis appears to be a risk factor for development of hypertension, but the converse has not been shown to be true. A lot of work is going on right now to try to sort of tease out these associations with these systemic diseases, so that's currently where we are at the moment. Okay, so here's a picture for everybody who is a visual learner. These are the various crystals that you can see whenever you do a urine analysis. With them, I don't know if you can read it properly, but there is their associated pH. So some of them are more prone to occur when there is an acidic pH, like uric acid stones, and then the triple phosphate stones, which is the one up there, is more an alkaline pH. So if we're lucky, we get to see these most of the time. By the time the urine has been spun and is sitting on the nursing station for the last hour and then taken to our lab, we don't necessarily get to see these wonderful images, but if this urine is spun almost immediately by one of our fellows or by anybody who wants to actually go and take a look at them in our 6th floor lab, we have seen some of these whenever we've been consulted. Okay, so the commonest stones by far are calcium stones. So the top 3 that you can see here, calcium oxalate and calcium phosphate combination, calcium oxalate alone, calcium phosphate alone, together make up about 70% of all stones. So the likelihood, if you do not know what the stone was because the patient did not bring their stone in or they already passed it, the likelihood is that it was a calcium stone, and that's important because then you can tailor your advice to the patient accordingly. Other stones are uric acid, struvite, and cysteine as well, and we'll talk a little bit about them. But essentially, those are stones that you will see in specific clinic scenarios where you will have clues that will tell you that these stones may not be calcium. So if you don't know what the stone is and the patient is otherwise healthy, doesn't really have any genetic disorders, no infections, they probably have a calcium stone. All right. So calcium stones, out of them, about 80% of them contain oxalate and about 15% are calcium phosphate alone. Very complex pathophysiology. All of these risk factors, some of which I will discuss, contribute towards the formation of stones. The number one that I've listed there is low urine volume. So as you know, the emphasis really is on increasing a patient's urine volume by increasing hydration. Other factors are hypercalciuria, which is the next most important. This is thought to be the number one pathophysiological factor in making somebody predisposed to nephrolithiasis. And then the rest are having high uric acid in the urine, low citrate, or high oxalate. Urine pH abnormalities as well. So hypercalciuria. Why do we get hypercalciuria? At this point, I just want to stop and say, having less calcium in your diet doesn't decrease the amount of calcium in your urine. So you never tell a patient, please have a low calcium diet. At the very best, they should be on normal calcium, if not a high calcium diet, depending on what their risk factors are. So please keep that in mind, and I'll show you why. Okay, this is the most prevalent abnormality of all of the various factors that cause nephrolithiasis. About half of all adults will have it if they have nephrolithiasis. There are several mechanisms by which you can have hypercalciuria. And they are divided into absorptive, resorptive, and renal. So if you remember that, you can forget about what the rest of this busy slide is trying to teach you. Absorptive basically means that you are increasing your intestinal calcium absorption, and so you'll have a high urine calcium. And again, this doesn't mean that you have so much calcium that you're increasing the absorption, which would make some sense. It's basically because of increased permeability of the intestine to calcium, which we will see in the next slide. This can be vitamin D dependent or vitamin D independent. So if it is vitamin D dependent, we can actually do something about it. So the vitamin D dependent patients with hypercalciuria basically have hypophosphatemia as well. And there is increased 125 hydroxyvitamin D production. Then there's resorptive hypercalciuria. This is primary hyperparathyroidism, essentially. So if you have a patient with primary hyperparathyroidism and nephrolithiasis, they have a calcium stone. And treating the hyperparathyroidism will help to alleviate this particular mechanism of calciuria. And then, of course, increased renal losses is if you have any tubular dysfunction that is causing calcium to get released into the urine without being reabsorbed. Now, some of these may coexist, and together they may lead to decreased bone mineral density and fractures as well. So that is another morbidity that we need to worry about in patients with nephrolithiasis. As far as research is concerned, this makes some logical sense. We have shown decreased bone mineral density in several studies, but really no overt association with fractures has yet been established, which is why it's not something that's commonly advertised. Okay, next risk factor is hyperuricasuria. So that's about 10% of calcium stone formers. So it's not just the uric acid stones, we're also worrying about the calcium stones in the patients who have more uric acid. Now, out of these, what can you do about it? Well, theoretically, a high purine diet will, which is lots of red meat, for those of you who don't know what high purine diet is, may contribute to excessive amounts of uric acid in the urine. But please remember that endogenous uric acid production does occur in about 1/3 of patients with no effective dietary restriction. Now, I don't think that means we should just ignore the dietary restriction of urine and say, hey, you may or may not just have too much uric acid endogenously, so go ahead and eat whatever you like. In a lot of these patients, the care has got to be individualized, and if there is a correlation, especially if the patient can tell you about where they can correlate the stone with having diets that are high in purine, by all means go ahead and advise them to reduce it. And in any case, one might argue that would be good advice in the general population to begin with. Okay, so low citrate in the urine. So the major determinant of this is acid-base balance. All right, so once again, distal RTAs, if the patient has RTAs, which is evidenced by a normal anion gap acidosis in your BMP. So you see a low bicarbonate, you look at the anion gap is normal. And the patient has hypokalemia. So these are the ways you diagnose any distal RTA. But if you have nephrolithiasis, you see these abnormalities, you get a little bit suspicious. Now, taking that a little bit further, the distal RTAs are common in several systemic diseases, autoimmune diseases, multiple myelomas. So these are those patients that may be prone to calcium stones from hypocitrate urea specifically. Hyperaldo states, thiazide use. Keep in mind that thiazide use with hypokalemia can cause this problem, because as you see later on, thiazide diuretics are actually used to treat stones in certain diseases as well. So again, the message here is you have to tailor the therapy to the individual's needs. What are the modifiable factors? I've tried to highlight the modifiable factors in these slides so that the take-home message for you guys is what can you tell the patient. High protein and high salt diets also predispose you to hypocitrate urea, and this is something that can be addressed by the patient. Really, you can't address distal RTA in terms of getting rid of the disease. You can only treat it by fixing the electrolyte abnormalities, and that will decrease the incidence of nephrolithiasis in the patients. But as far as dietary factors are concerned, you could do that. Okay, so why does this happen? Well, basically you have reduction of urinary saturation with respect to the calcium salts, and also the calcium oxalate crystallization process is inhibited if there isn't enough citrate in the urine. So you need citrate in the urine. Hyperoxaluria, again, more oxalate in the urine. This can happen because of oxalate overproduction. A number of inborn errors of metabolism, just listed them to show you that they do exist, but again, increased dietary intake of oxalate and bioavailability can make a difference. And I wouldn't go as far as decreasing all oxalate in a patient's diet till you have evidence of this, and we'll talk about getting 24-hour urinary profiles when we do a diagnostic workup, because there are some things that are high in oxalate that are actually good for you. So we don't want to, unnecessarily remove things from a patient's diet that are healthy unless we have proof that this is causing recurrent nephrolithiasis. Okay, so what happens? You get increased intestinal oxalate absorption. This can happen with chronic diarrhea, inflammatory bowel disease, such as Crohn's. See a lot of Crohn's patients developing stones because of this abnormality, and intestinal resection. We're seeing a lot more of this where you have gastric bypass and shortcut syndrome. We have a lot of patients like this that have poor, gut absorption. So that's one way you can get it. Now you can also get it in conjunction with low urine volume and hypocytraturia. So essentially, most of these stones, you need a combination of these factors to be predisposed to stone. Having hyperoxaluria alone probably doesn't cause a stone. That, in addition to a lower urine volume, especially a low urine volume and hypocytraturia, will make the milieu, as it were, more prone to nephrolithiasis. Urinary pH, both extremes can lead to stones. Acidic pH will cause supersaturation of undissociated uric acid, and you'll get crystallization of the calcium and oxalate. Alkaline pH is more hydroxyapatite and calcium combinations. And then again, systemic diseases that will alter the urinary pH include all the renal tubular acidosis, really, because they all cause alkaline pH, primary hyperparathyroidism, and carbonic anhydrase inhibitor use, which we don't use too much of, but we have still some specialties that do use them for some patients. Okay, so how do these stones form? This is an area that is still under extensive study, and there are 3 major theories as to why this happens. You can actually have more than one of these mechanisms happening in the same patients. The most popular theory is the first one, which is called the supersaturation theory, which I'm going to talk about a little more. And essentially, you have, well, we'll talk about that actually in the next slide, what supersaturation is. The second one is the classic Randall's plaque. I'm not sure if some of you remember that from medical school, but essentially there's already a plaque, and then the stones anchor onto it and grow on it and eventually cause an obstruction. And this plaque correlates with low urine volume again. So if you have the plaque already and you have adequate urine volumes, you probably will not get nephrolithiasis. Calcium phosphate stones themselves physically can cause the obstruction, which means that they've crystallized to such an extent that they're producing plugs and causing scarring. So there's basically anatomical obstruction, or a known plaque, or supersaturation of having too many of these things in the urine and they need to crystallize. So the supersaturation theory, basically, saturation level for basic chemistry here is the specific concentration of level of a salt equals their solubility product, and you cannot dissolve any more salt. So crystals will form. And this will depend on their chemical-free ion activities. So this again depends on concentration, urine pH, and complexing with other substances in the urine. So very simply put, the urine is saturated, and then it gets supersaturated. Then there's a crystal nucleation around which there's aggregation of the calcium and the calcium phosphate, and then you get retention and growth, and a stone forms. Okay. There is also a genetic basis of calcium stone formation, which is why I think it is very difficult to do a one-size-fits-all approach to a patient with nephrolithiasis. It has been shown that there is an increased incidence with first-degree relatives and family members with stones. You also have a number of genetic disorders that we know are hereditary, such as Barter's, dent disease, a whole other bunch of electrolyte abnormalities that are genetic that predispose you to calcium stone formation. There's also been greater concordance shown with monozygotic twins, and some genes that are implicated, are these ADCY10 and Claudin and the calcium sensing receptor genes. So there is some evidence that whatever we do, some of us are more genetically predisposed to nephrolithiasis and others aren't. So we can't completely get rid of the risk in everybody. But again, my focus would be to focus on the modifiable risk factors and not focus too much on what can't be changed in patients. Uric acid stones, they usually happen when the urine pH is acidic, And again, low urine volume, hyperuricosuria, and again, there are genetic associations with uric acid stones. Cystinuria is very, very specific. It's basically more prevalent in kids and adolescents. It's an autosomal recessive or autosomal dominant disease. There is an inherited defect in renal cystine reabsorption, and then you'll have different mutations. So you will see a very specific population, and most of us, maybe except for our MedPeds colleagues, won't see it or won't feel a reason to suspect it, unless they already have a genetic disorder. Okay, what else can cause stones? There's a few other miscellaneous things in the basket. You can also get stones from steroids, vitamin D and calcium supplementation, and I'm talking about grams and grams and grams of antacid use and Tums. So again, this is not to say stop giving people calcium, tell them to have, stop drinking milk. This is those patients that are slightly pathological about this and are having bottles and bottles of antacid because they have gastritis, and we've seen stuff like that happen. They may develop hypercalciuria because of their supersaturation to that point because of increased diet, but it's quite rare and too rare for us to counsel patients to stop taking calcium. Hyperoxaluria, vitamin C and B6 can increase intestinal absorption. The indiniver is very interesting because indiniver themselves, the stone contains indiniver. So it's called an indiniver stone. And what makes it interesting is therefore its composition is none of the above. And secondly, it is the one stone that is actually not seen even on CT, so you can miss them if you do the regular workup. So if a patient has HIV and they look like they have stone disease and they're having hematuria and you cannot find that stone, they could still have a stone which is the indiniver stone. Okay. What else? Infectious causes. This happens in the presence of highly alkaline urine. It always exceeds 7, and there's usually urease producing organisms. And of course, the antibiotic usage that goes along with these infections reduce the intestinal O-formagenase levels, which is the main energy source of oxalate. Very rarely, we also see some ammonium and dihydroxyadanine crystals. Okay. So how do stones present? Now you have an idea. The bottom line in the previous section basically was that most stones are made of calcium in some form or the other. There's a whole bunch of risk factors, some modifiable, some not. So a patient comes in, there is pain. It's supposedly the most painful condition one has ever encountered for those of us who have had stones. And this pain is thought to be secondary to the hydrostatic pressure that causes renal capsular distension. So the pain traditionally passes from the flank anteriorly to the groin. It really all depends on when you catch the patient having pain, where they are in the passage of their stone, and how high their pain threshold is. Maybe there's somebody who has low back pain chronically to begin with, so they don't really notice that they have a stone until the pain has hit the groin. So they don't necessarily all present the same way. Once the stone is at the UV junction is when you start getting the dysuria and the hematuria. So if the patient starts feeling the burning, the urine, the dysuria, they probably have already reached the UV junction. About 75% of patients have the macroscopic hematuria. So if you do a urine analysis, you'll see that, but less than a fifth of them will have gross hematuria. There is associated nausea and vomiting as well. Okay, is the stone going to pass? Is the stone not going to pass? Likelihood is obviously less as the stone gets bigger. Generally, if the stone exceeds 5 millimeters, you give them a follow-up with urology at the very least, or you follow them for a day, or you try to plan for some intervention. And if it's less than that, you're pretty safe in going ahead and just treating them conservatively and tell them to come back if they really need to. All right, diagnosis. Okay, take a good history. Now again, the emphasis here is, when patients have a stone for the first time, none of this is going on these days. You basically say that was your first stone, drink lots of water and go home. That is the advice patients are given. However, as we saw in the first slide, the rate of recurrence is pretty significant, and it increases with every year that patients are living, and patients are living for longer. So it is a good idea to start taking a history of what is predisposing them to nephrolithiasis and addressing it so that they can prevent that second stone, in addition to maybe uncovering systemic diseases that the patient had all along that needs addressing. So identifying environmental and systemic influences obviously starts with, are you drinking enough water? Were you dehydrated? Were you working out in the sun, et cetera, et cetera? Then moving on to the disorders of calcium homeostasis, which would, again, they may just tell you, I have primary hyperparathyroidism or any vitamin D metabolism diseases. They may be obese, they may have diabetes. If they have a history of recurrent UTI, it would guide you towards what kind of a stone this is. This may not be a calcium stone. Bariatric surgery, medullary sponge kidney, and then of course diet. What kind of diet are you taking? High salt, protein, low calcium, climates, and exercise intensity. Okay, so what do? Ideally, every patient should get a stone analysis. This is not occurring right now in terms of our emergency rooms or primary care clinic. If the patient brings the stone, do everybody a favor and get it analyzed. They don't bring it, too bad. But if they bring it, it is a good idea to analyze it, again, because there's a lot of emphasis now on preventing that recurrence. Traditionally, we were only going down this route once the patient had a second stone. That's really what has changed in the past decade, if I were to sort of name one thing. And again, you may find a stone that is not calcium oxalate and find other things that are modifiable. Imaging, I've jumped straight to CT because quite honestly, these days you really can't rule out stone disease. And even then, if the patient has an diminished stone, you may not even then be able to rule it out without a CAT scan. Yes, you can do X-rays, you can do IVP. There's even ultrasounds being done. If you're lucky, the stone is big enough and it's a large calcium oxalate stone, sure, you'll be able to visualize it. But having a negative one of any of those studies does not rule out nephrolithiasis. So really, this is the one case I would say jumping to a CT is perfectly acceptable. Okay, what else? Well, basic lab, because you can get fasting blood calcium, low phosphorus from just the basic metabolic profile. If you are suspecting hyperparathyroidism, then you can do a PTH as well. Now, if you have high PTH with nephrolithiasis, you must consider that patient for a localization study and parathyroidectomy. It is one of the indications to consider it if there is no other contraindication to it. If you have low serum phosphorus but everything else is normal, that means you might have some phosphorus leaking through the kidneys, which again points to some renal defect. If you have a low serum potassium and low bicarb, as I have mentioned earlier, that's suggestive of distal RTA. So most of this data, except for the PTH, is you can get from a basic metabolic panel, which every patient literally, stubbing their toe and walking through the ER has a BMP in the chart nowadays. Hyperuricemia and hypertriglyceridemia can also be encountered in patients with uric acid stones. But do remember, if it's hyperuricuria, the high uric acid in the urine, you're still likely to have the calcium stone and the uric acid. So keep that statistic in mind. What about this metabolic evaluation? So this is basically another main question that gets asked really a lot of the nephrologists and urologists. Should everybody get this? This is very opinion based. Still cannot find one guideline anywhere that says it must be done day one of the first patient. Most of the sort of editorials and expert opinions and things that I read basically recommend this in a recurrent stone former because it is a little bit more labor intensive to do, or if the patient has a family history of stones, or you're already getting bone fractures, or have some predisposing factor in the history that tells you that this patient is going to be a recurrent stone former, such as an RTA or chronic diarrhea. So what is this metabolic evaluation? This is a 24-hour urinary profile. You have to send it, basically get the patient to bring the jug of urine, make sure that the volume is adequate. If the volume is not adequate, then you have to reinterpret all of these numbers that I have listed here. It is very difficult to do. You also have to get a urinary creatinine so that you know that the sample is adequate. Make sure that it's about 20 to 25 mg per kg, whatever the creatinine is, so it's an adequate collection. Okay, so now you've decided it's an adequate collection. You send it for all of these things: calcium, uric acid, oxalate, citrate, and these are the cutoffs for what they should or should not be. M is male and F is female. So, for example, the calcium should be around about less than 300 milligrams in males and less than 250 in females. You can also check the sodium. Basically, you can send a urine for everything, but you have to make sure that your lab does it. You have to make sure that it's collected properly and that you've actually ordered each and every one of these things. And of course, you check the urine pH as well. The advantage of doing this is to know which of those risk factors that the patient has. Do they have hypocalciuria? Do they have hyperoxaluria? And tailor your dietary advice towards that. So a lot of people might argue, which is why we only do this a second time, is some of the dietary advice is common sense: low salt diet, high volume, low purine. Again, if the patient is determined not to make any dietary changes, you might want to do this right off the bat. But most of the time, if they have risk factors, have had a second stone, you've not been successful in elucidating the cause, is when you would do this. Okay, so that's pretty much how you diagnose a stone, imaging the stone itself, and then the profile. What do you do about it? So there are several conservative options which are well within the realm of a primary care doctor. So I think everybody should focus on this as much as they can. High oral fluid intake. The goal is to have more than 2 liters of urine volume. So think about that in all of yourselves in the hot summer months. And it's about 2.5 liters of fluid, which again is quite difficult to achieve. I say that for myself for sure. And if you get that, then there has been association with reduced urinary supersaturation. So basically, if you have less than that, we actually haven't shown a reduction of this supersaturation. So just by saying, hey, have an extra couple of glasses of water a day, makes sense that it might reduce your risk of nephrolithiasis, but the only associations that have been actually shown to bear this out are volumes that are quite excessive. So fluid intake such as fruit juice, so a lot of residents ask what should they drink, what should they not drink. Orange juice has been shown to be effective in reducing urinary calcium oxalate saturation, so a glass of orange juice for everybody, and increasing urinary citrate excretion. This is not true for apple juice, this is not true for grape juice, colas, which should be avoided anyway, and some sports drinks. They have high oxalate content, and that kind of negates what you're trying to do to begin with. Okay, so water and orange juice. Low sodium diet, which is about less than 100 MEQ per day. What else? Low animal proteins, normal calcium intake. Again, emphasis on normal calcium intake. I know for sure there is a board question here as far as the calcium is concerned. Dietary oxalate restriction is also useful if the hyperoxaluria is a problem. So, but look at the fruits that raise it. Raspberries, figs, plums. You don't really want to tell patients stop eating all of this unless you're fairly certain that this is contributing to nephrolithiasis, or the patient really has painful recurrent nephrolithiasis and want to do everything they can to eliminate the chances of having another one. How about the vitamin D? Nothing really has come out to say, hey, more vitamin D is better or less is better, because as you saw, some of those mechanisms, they were vitamin D dependent, some were vitamin D independent. It's really difficult to tease this out. So about 800 international units per day is a general recommendation. And I think if you don't have nephrolithiasis, you really don't have to supplement your vitamin D. Okay, what about drugs? There are drugs out there to treat patients. Patients might want to know, how can I prevent this just by taking a medication? Is there a medication out there for this? Again, consider this in recurrent calcium kidney stone formers or specific stones such as cystine, infections, etc. Okay, so what are they? The thiazide diuretics are the most commonly used medications to treat stones, but remember the thiazide diuretics and a low salt diet together was contributing to that hypocitraturia. So keep in mind that you don't necessarily alleviate everybody's stones with thiazide diuretics. Okay. So, but they have been shown to be effective in reducing kidney stone recurrence in several studies. So that's why they're the most commonly used. They treat hypercalciuria, they treat reduced stone recurrence regardless of the pathological mechanisms. But you must have this with a low salt diet. And this is really the key here. If you put the patient on thiazide, say, look, if you have this and then you have a high salt diet, no point in being on thiazides. So you have to make sure that you counsel the patient appropriately, because otherwise you're going to get the hypocitraturia. What else? Should we alkalinize urine or not? Well, what does acid loading do? It will increase the renal calcium reabsorption, and then it will increase hypercalciuria with that mechanism. That's the premise for which we use alkaline. So you can use potassium citrate either alone or in combination with the thiazide. Again, calcium and uric acid stones. These are the two stone populations you can do this for. And it's not particularly harmful unless the patient has a reason to have high potassium. Giving thiazide and potassium citrate combination is fairly innocuous if you're treating recurrent stone formations. Okay, what else? Also, alkali treatment has a lot of other beneficial effects as far as stones. Reduces the urinary calcium oxalate and calcium phosphate and undissociated uric acid supersaturation. All of these things, in addition to preventing recurrent stones, also show increased bone mineral density in the kidney stone forming population, but not just in any random patient. But again, we haven't been able to show a decrease in the fracture rate, but we assume that it should be there if we're increasing bone mineral density. And that's trials for you. Okay, allopurinol can also be used for uric acid stones, and if you have hyperuricasuria, consider it. Not in every patient, and do not correlate this with serum uric acid. There is no correlation. If you really want to correlate it, get a urine uric acid, and if that's high, then think about using allopurinol. And again, combination with thiazides. Everything is thiazides with all of these really, if you are wanting it to work, just because that's what most of the studies have been done on the thiazides. Okay, there are a couple of other medications. Cystinuria has 1 or 2 medications specific for it. There's this relatively new medicine. I don't think it's new, but this indication is acetohydroxamic acid, which has been used for infectious kidney disease stones. But I mean, the ideal therapy for any infectious kidney stone is surgery and antibiotics. So if that you cannot do, apparently this is an option. I've never seen it used, and it's very, very poorly tolerated. But it is out there in case there is somebody who's not a surgical candidate, bariatric patients, things like that. Okay, so there's medicine, there's surgery. Patient is sitting in your clinic, they will ask you, it's not a matter of them, they may ask you, what are my surgical options? Can I get rid of the stone? I've heard of lithotripsy, do I need it? Do I need to go through all of this and have my low salt, or can I just get rid of the stone? So who gets stones? Who gets surgical therapies? Okay, if you have persistent obstruction from the stone, so if you are going to pass that stone, and per my previous slide, if it's less than 5 millimeters, please don't even worry about any of this unless the patient comes back with another one or it is larger than that. The stone does not progress through the urinary tract, does not get passed. So the patient comes in a week later, says, doc, I still have pain, it's still there. Or if, again, there is unremitting colic. So that's when you would consider surgery. At this point, really, you would refer the patient to a urologist and let them decide who's going to need what kind of surgery. There are a lot of different, surgical options out there, but the main one and the most popular one, which is why I have highlighted it in each of the different kinds of stone, is the ureteroscopy. There is shockwave lithotripsy, there's laser lithotripsy, there's also open removal, which is still an option, but is very, very rarely done now because of these other non-invasive therapies. So if your patient has a proximal calculus and is less than 10 millimeters, you can do shockwave lithotripsy. Pretty much that's the only time now that's the indication to do it, even though that's when this field started, that was the treatment of choice. Now it's ureteroscopy as first line therapy, and if it's a larger stone, it's again ureteroscopy as first line therapy. If it's mid-ureteral, again ureteroscopy is the first line therapy, and again for distal it's the same. So having said that, stone-free rates are high with both techniques, and some clinicians prefer shockwave. So you may have, it's really operator dependent. You may have a urologist who only has the shockwave lithotripsy capability in his clinic or her clinic, and you would go with the procedure that the physician is the most accustomed to using. Okay, so there are other techniques, percutaneous ureteroscopies and retroperitoneal laparoscopies and even open surgery, but again, they're not likely to be successful, and also they're invasive. Okay, so when do you really need to go in? If the stone is very, very large, if the stone is complex, if there are cystine stones tend to be resistant to shockwave lithotripsy. And then again, ureteroscopy, mentioning this really repetition, they are the most popular procedures right now. Okay, I'm going to leave you with this. So in the end, you have a lot of information about what you should be doing in terms of diagnosing a stone, in terms of working up a patient with nephrolithiasis. When do you work them up? What kind of workup do you do? But what are the guidelines? Do we have guidelines out there? Well, the ACP came up with their dietary and pharmacological management to prevent nephrolithiasis. This is back from November 2014, so it's relatively recent. But there are 2 recommendations. It's like a 3-page article. I was expecting sort of a 20-page thing after I found this last night after I'd finished preparing this, and I said, oh, there it all is. It's actually just 2 pages. There's really not enough data out there as far as the ACP is concerned. They did a whole Cochrane database, Medline search, and they list all the trials that they have assessed. They have not assessed enough of them to be of high-grade evidence enough to make clear-cut, high-grade recommendations for anything. So the 2 recommendations are increased fluid intake, which we've talked about ad nauseum, and again, it's a weak recommendation with low-quality evidence with not even a number assigned to it. And recommendation 2, pharmacological monotherapy with a thiazide diuretic citrate or allopurinol, which again I mentioned for recurrent nephrolithiasis. The quality evidence of this was moderate, and I can tell you that it was moderate because the thiazide diuretic trials are still, somewhat decent. So in the end, it's still a very sort of actively research field. It is still a very individualized therapy. It is still not a one-size-fits-all, and you have to take each patient's symptoms and risk factors into account. There isn't going to be a set of guidelines for you to just read off of and decide what you're going to do. Those are my references. And questions? No questions? Okay.